Then some of the important medico-legal facts related to the copper are it is an abortifacient. It can be used as a cattle poison. It is used as a chestnut compound in the horticulture to prevent the fungal diseases. There it may cause the poisoning. Then regarding manner of the poisoning, it can occur with all the modes. However, the accidental poisoning is the commonest. Suicidal and homicidal poisoning is the rare of the rarest due to the copper intoxication. Accidental poisoning is very well common. Accidental ingestion in the children is common due to shining color of the copper crystals. Children get attracted to it, thinking it as a sweet or the eating objects. Coin ingestion is also a common phenomenon. Indian coins contains the cupro-nickel compound. It may be accidentally ingested. Copper cookware, especially tea kettles, can cause the copper toxicity with frequent use. Soft drink carbonated soda dispenses in case of equipment failure leads to the copper salt mixing with the soft drink, causing the chronic poisoning. Storage of acidic juices in the copper vessels may cause poisoning. Copper salt used to enhance the green color of the vegetable can cause poisoning if not washed properly before the consumption. Stagnant or hot water in the copper pipes can accumulate copper ions leading to the poisoning. All these conditions can be the reason for the accidental ingestion of the copper substance. For homicidal purpose, copper is rarely used due to its color and the taste, but it may be mixed with the dark or blue colored liquids. Copper salts are relatively accessible in the cottage industries and can be used to commit suicide. Copper has certain medicinal values where it can cause poisoning, like copper is utilized in the various medical applications which can lead to the iatrogenic poisoning. It is used in burn treatment, contraceptive pills, dental material and as an emetics. Copper poisoning can occur if the acidic water is used in the hemodialysis. Copper tubing in dialysis machine may release the copper ion. There also it can cause the toxicity. Then the certain reagents in the biochemistry uses the copper and their accidental poisoning with the copper can occur. Like the copper sulfate is a component of the reagents like Benedict solutions and the Fehling solution used in the biochemical tests. Then one of the interesting facts of the copper is the green color or the solution of the copper sulfate are used in the religious ceremonies, particularly in the Nigeria, for inducing emesis as a symbol of expelling sins and impurities and can lead to the poisoning. Then the metal fume fever, that is an occupational disease seen in the smelters. Metal fume fever is a self-limiting febrile illness that occurs in those individuals that fuse metals. Welders are also involved in filling indentations and seams in the metals. Metal fume fever presents as a flu-like syndrome occurring shortly after these activities and others where metals are bound altogether. Interesting fact about the metal fume fever is that improvement occurs over the course of the work week, but re-exposure after the work results in the return of the symptoms such as fever, malaise and wheezing. For this reason, it is called as the Monday morning fever. The first reported case of the metal fume fever were in the 1830s. Other common names of the metal fume fever is given as brass chills, brass founders ague, brazier's disease, copper fever, foundry fever, galvanizer's poisoning, smelter's chills, zinc fume fever. In most cases, the illness resulting from copper exposure tends to be the mild and the self-limiting. Treatment is primarily focused on addressing the symptoms like antipyretics for the fever, fluid to combat the dehydration, oxygen therapy to alleviate the hypoxemia. In cases where the bronchospasm is prominent, inhaled beta agonist and glucocorticoids may be beneficial in relieving symptoms and improving the respiratory functions. In this way, the metal fume fever is presented. Understanding the diverse roles and hazards associated with copper is crucial for the safe handling and management across the various fields. Understanding the diverse roles and hazard associated with copper is crucial for its safe handling and management across various fields. This is all related to the copper poisoning. Then coming to the another poison, that is the iron. Iron toxicity, though used for centuries, was only recognized in mid 20th century. By 1990s, it became the leading cause of poisoning death in children under the 6 years of age. In response, the FDA mandated warning labels on all iron containing products in 1997, aiming to prevent pediatric iron poisoning. Measures included unit dosing for the prescription with over 30 mg of elemental iron and limiting pill dispensing to the 30 days of the supply only. These actions significantly reduced the iron poisoning incidents. However, the FDA rescinded the blister packaging requirement in 2003. Newer non-ionic forms like carbonyl iron and iron polysaccharides are thought to be less toxic than the iron salts. I have already discussed with you a case report where the young female consumed the government supplied iron tablets in large quantities and presented with fatal symptoms of the iron poisoning. Metallic iron exhibits a silvery white hue and occurs naturally as hematite, magnetite, and other minerals, typically posing no issues. It is vital element and its deficiency can lead to the anemia. Some individuals with the genetic conditions such as hemochromatosis, that is also known as bronze diabetes, may experience toxic effects from the normal dietary iron due to its accumulation. Therapeutically, various iron salts are administered to treat the iron deficiency anemia, which can stem from the various causes. Iron poisoning primarily results from overdosing on the such salt. Ferrous sulfate, commonly known as green vitriol, is one of the most prevalent forms, presenting as the bluish-green crystals, as you can see in the picture. It is important to know that iron oxide, that is rust, doesn't induce any iron poisoning. Different sources of the irons are the dietary source. The average daily intake of adult of the iron is about 15 milligram. Then the environmental sources. Iron is found in 5.1% of the Earth's crust. It is the second most abundant metal. Then for industrial purposes, iron is used in powder metallurgy and serves as a catalyst in the various chemical reactions. Steel is an important alloy of the iron. Then iron poisoning occurs when the serum iron level exceeds the total iron binding capacity, resulting in the free circulating iron in the blood stream. Free iron causes massive post-arterial dilation, which results in the venous pooling. It causes increased capillary permeability, resulting in decreased plasma volume. Oxidation of ferrous to ferric iron, releasing hydrogen ion, subsequently causes hydration of the ferric ion that results in the metabolic acidosis. It inhibits the mitochondrial function, leading to hepatic damage, hypoglycemia, and the hypoprothrombemia. It inhibits the thrombin-induced conversion of fibrinogen into fibrin. It has direct corrosive action on the gastrointestinal mucosa. Fatal dosing related to the iron are the, for mild cases, it is 20 milligram per kg. Moderate presentation is seen at 40 milligram per kg, and it is fatal to death in case of the poisoning of 60 milligram per kg. Fatal period with fatal dose is about 1 to 2 days. Then coming to the clinical presentation in case of iron poisoning. Features of the iron poisoning is usually seen in the 5 stages. Stage 1 is the gastrointestinal stage that occurs from half an hour to the 2 hours. In this, the patient presents with the vomiting, hematomesis, abdominal pain, diarrhea, hematochezia, lethargy, shock, acidosis, and coagulopathy. Iron causes necrosis to the gastrointestinal tract, directly leading to the severe gastrointestinal hemorrhagic necrosis and fluid loss, contributing to the shock. Vasodilatation induced by the free iron and ferritin may also contribute to the shock. Then stage 2 is characterized by the latent phase, that occurs from 6 hours to 12 hours period of after the stage 1. It is characterized by apparent recovery, that is patient is well, there is no symptoms, potentially creating a false sense of security. Close observation is necessary at this stage. Stage 3 is characterized by metabolic and cardiovascular effects that occurs from 2 hours to 24 hours after the stage 1. Symptoms include the profound shock, severe acidosis, cyanosis and fever. Cases has presented with the increased total peripheral resistance, decreased plasma volumes, hemoconcentration, decreased total blood volume, hypotension, CNS depression and metabolic acidosis. Stage 4 is the hepatic stage that occurs 2 to 4 days after the initial presentation. It may involve hepatotoxicity, convulsion and coma believed to result from direct action of iron on the mitochondria. Monitoring of the liver function test and bilirubin is essential. Acute lung injury may occur at this stage. Hepatic injury primarily affect the periportal areas of the hepatic lobules, possibly explaining the increased mortality and the poor prognosis. Iron-induced hepatotoxicity is presumed to occur due to free radical generation and the lipid peroxidation. Antioxidants may play hepatoprotective roles. Then the stage 5, that is delayed stage, that occurs days to weeks after stage 1. It includes the gastrointestinal scarring and the strictures. Gastrointestinal obstruction secondary to gastric or pyrolic scarring may result from the corrosive effect of the iron. In that case that I discussed, the pyrolic scarring along with the intestinal obstruction was present. Evaluation with the barium contrast studies is recommended. Sustained release preparation of the iron compounds have led to the small intestinal necrosis with resultant scarring and obstruction. It is important to know that these stages of the iron poisoning may not occur in all the patients. So, after stage 1, it can go directly to the stage 3 or stage 4. Likewise, could be the possibility. It is not the necessity that all the stages will be present in every cases. Then for the diagnosis of the iron poisoning, X-ray is of use as the ironates compound are typically radio-opaque. However, certain chewable iron tablets and liquid formulations may not appear on the X-rays. Then serum iron level is the important diagnostic parameter. Poisoning is indicated if serum iron level exceeds 150 microgram per 100 ml. Serious toxicity is usually associated with levels beyond 500 to 600 microgram per 100 ml. Peak level is observed approximately 4 hours post ingestion of the iron. So, accurate blood level may be taken after the 4 hours of the ingestion. Then the chelation challenge test is of help. In the chelation challenge test, desferoxamine is administered at the 25 milligram per kg. Under the chelation challenge test, desferoxamine is administered at the 25 milligram per kg intramuscularly. Excess iron is chelated to desferoxamine and excreted as the pinkish wine rose color. As you can see in the picture, this is the wine rose color in urine. A negative test doesn't rule out the iron poisoning. This is basic fact related to the chelation challenge test. Then for qualitative desferoxamine color test, gastric fluid is mixed with the 30% hydrogen peroxide. Desferoxamine solution is added. Color change is compared with the control. Positive result in the orange or the red color. This test should be conducted within 2 hours of the iron ingestion. This can be used as a bedside test for the iron poisoning. Then additionally, the total leukocyte count, electrolytes, glucose, clotting factors, liver enzymes and the renal function test are valuable for the assessment and management accordingly as per the symptomatic and the laboratory presentation. And for management, stomach lavage should be done. Normal saline lavage may benefit in the massive ingestions. Desferoxamine should not be used for lavage. Activated charcoal is also not very effective. The reduction of iron absorption is done with the help of magnesium hydroxide solution 1% orally. It reduces the absorption by precipitating ferrous hydroxide. Magnesium hydroxide and calcium carbonate antacids can be used safely in the therapeutic doses. Whole bowel irrigation is useful. Whole bowel irrigation is done with the polyethylene glycol electrolyte lavage solution. It is done at the rate of the 500 milliliter per hour in children and 2 liter per hour in adults. Start slowly and increase gradually. Antiemetics like the metoclopramide can be used to treat the nausea and vomiting due to the ingestion of the polyethylene glycol. Then endoscopic interventions may be tried, particularly for removing tablets that is adherent to the gastric mucosa. Then the serial monitoring of the different parameters shall be done so that the improvement may be checked. Serum iron level, creatinine, electrolytes, hemoglobin concentration, prothrombin time, liver function test, ABJ should be obtained. Correct hypovolemia, correct metabolic acidosis with sodium bicarbonate, control of the convulsions, chelation therapy, then symptomatic measures shall be taken. The convulsions shall be treated with the IV diazepam or phenobarbital. Then chelation therapy is indicated when multiple episodes of vomiting or diarrhea with abdominal pain, hypovolemia, acidosis, multiple radioapicities on the abdominal X-ray, and the serum iron level is more than 350 microgram per 100 ml. Then the chelation with the desferoxamine is the agent of choice. Hemodialysis is not very effective in iron removal but may help to relieve the acute renal failure. Continuous arteriovenous hemofiltration may be beneficial in severe poisoning. Extensive transfusion may be considered in toddlers with severe poisoning to remove free iron from the blood. Liver transplantation may be considered in case of fulminant liver failure. Then in case of iron toxicity, main reason for the death is the shock, and the second commonest cause is the hepatotoxicity. On postmortem, although not very characteristic features are seen, but hemorrhagic necrosis of the gastric mucosa. In the ferrous sulfate poisoning, that is blue vitriol, gastric contents may appear bluish green in color, and also the lining of the mucosa will be the bluish green color. Features of the gastrointestinal scarring, necrosis and the intestinal obstruction may be seen. Hepatic necrosis may be observed. All the 5 stages that may be seen in the case of the autopsy of the patient. Renal necrosis and the degenerative tubular changes may be seen. On histopathological examination of tissues, various special stains may be used to confirm the diagnosis of the iron poisoning. So, histopathology may also be of help in case of the metallic poisons. Apart from the toxicological analysis report that will be of certain value, then the certain other medico-legal important facts are that it resembles with the blood stain. The iron oxide, that is rust, has to be ruled out with the blood stain. Accidental poisoning is the common with the iron that occurs commonly, as the brightly colored and flavored iron preparation may attract children, leading to accidental ingestion. Homicide and suicide with the iron is usually rare. This is all related to the iron toxicity. Thank you.